So what do you want to start with?
Anaphylaxis.
Anaphylaxis? All right.
Yes.
Fine. So 7 participants. Okay. We'll just wait for 2 more minutes and then we'll get on with it.
Okay. Okay.
Because I also have to go somewhere. So we'll try to wrap it up within 1 hour.
Yes.
Okay, 6 participants. Okay, I think it's time we can start. Okay, sir.
Yes,
How
sir.
do you define anaphylaxis?
The anaphylaxis is basically a type 1 hypersensitivity reaction.
Yes.
It is caused by when antigen combined with the immunoglobulin E. It
Yes.
activates the mast cell and causes degranulation, and various anaphylatoxins are released like histamine, bradykinin, platelet activating factor, and these causes the physiological effect like vascular permeability, increased vascular permeability, vasodilatation, and smooth muscle constriction.
Yes, yes, correct. So anaphylaxis, it can occur at the first exposure?
Mostly, most of the time it requires prior exposure, but
yes.
it can also occur on the first exposure sometimes, rarely.
Okay. So is it required that the same substance exposure?
No, there can be cross sensitivity can be there.
All right. All right. Okay. So what are the common causes of anaphylaxis inside the operating room?
Most common are neuromuscular blockers and latex, then antibiotics. In antibiotics, beta-lactams, sulfa drugs, and vancomycin and protamine. These
so
are
commonly you said it's muscle relaxants?
Yes, commonly it's muscle relaxants.
Actually, it's antibiotics which is highest, that is 46%. Okay. Then comes muscle relaxants around 33%, and then next comes chlorhexidine. Chlorhexidine is 10%.
Okay.
So, which is the muscle relaxant which is known to cause anaphylaxis most commonly?
Most commonly atracurium. Atracurium. Not sure.
No, it's rocuronium actually.
Okay.
All right. Yeah.
Yes, sir.
Okay. Yeah. And then chlorhexidine, when can it cause? When you're painting for spinal, okay, or when the surgeon is painting, prior to the procedure, okay. So these are the times when you have to be, aware that there's a possibility. All right. So how do you diagnose intraoperatively?
There can be this flushing of the skin, redness of the face, then edema of the lips, edema of the face, edema of the airway, and then respiratory symptoms like increased airway pressure, bronchospasm, wheezing, and pulmonary edema, and then the cardiovascular, because of this increased extravascular extravasation, there can be sudden hypotension, tachycardia, and cardiovascular collapse. And malignant arrhythmia.
Any respiratory?
Respiratory, I told that bronchospasm, wheezing.
Yeah, bronchospasm. So how will you see it as rising airway pressures, right?
Yes, rising airway pressure.
So most commonly, around 51% the times it's cardiovascular collapse. And about 45% of times presentation can be flushing, wheals, and rashes. And then respiratory around 40% incidence. All right.
Yes.
So if there is an anaphylactic reaction, what could be the differential diagnosis in that situation?
Differential diagnosis can be this acute exacerbation of asthma or COPD, and myocardial infarction. There can be malignant this hyperpyrexia.
Yes.
Then hemorrhage. These are the common causes.
What about neuraxial blockade?
Yes, high regional block, high spinal block.
So you have to think of all possible things that we do in the OT, and then you have to mention. So usually, if there is hypotension, wherever there is a question about hypotension, you can always mention a high neurological blockade, high regional blockade. All right.
Yes, sir. Yes, sir.
So what is the difference between anaphylactic and anaphylactoid reaction?
So clinically, both manifest almost in the same way.
Yes.
But in anaphylactoid reaction, it is basically direct activation of the complement system. Correct. Or IgG mediated complement.
Yes. So anaphylactoid reaction is not a less severe thing.
Yes, sir.
Some people try to think that it is less severe. They try to answer that it's less severe compared to anaphylactic. It is not so. Both can be as terrible as possible. The only difference is basically this is IgE and that's IgG, right?
Yes, sir.
So how do you manage a suspected anaphylactic reaction inside the OR?
The first is immediate management. We need to shout and call for help.
Yes, correct.
Declare it as an emergency, and then stop the offending drug. Ventilate with 100% oxygen. Ask the surgeon to stop the surgery, and then ABCD approach: airway, breathing, and circulation. We need to see. If then injection ADR, adrenaline. 50 to 100 mics, that is 0.5 to 1 ml of 1:10,000 IV every minute till the situation is under control. And if there is cardiovascular collapse or malignant arrhythmia, then we need to treat as per ACLS protocol. And if then in the end we need to think of this cardiopulmonary bypass or ECMO. And then the subsequent management, we can use the steroids, this hydrocortisone.
So what you talked right now is immediate management.
Yes, sir.
So next is early management. So what all will you give in early management?
This antihistaminic, like diphenhydramine, about 50 to 100 milligram IV. Then steroid, hydrocortisone.
Any other antihistaminic you can use regularly that we use?
This chlorpheniramine.
Yes. Dose, please.
25 milligram, 25 or 50 milligram 1 ampule contains. I don't remember exactly.
Okay, no problem. The dose is 10 to 22.5 milligram IV. Okay, next. What else?
Next is steroid, this hydrocortisone 200 milligram IV. or methylprednisolone 1 to 2 milligram per kg IV we can give.
Correct.
Then injection Rentex we can use 150 milligram IV. And
what did you say?
Ranitidine, injection ranitidine.
Is it used that commonly?
No.
But it's a book says.
Okay.
Book says because there is some part when H1 and H2 receptor symptoms cause because of that. It is H2 blocker, so we can use it. Ranitidine 150 milligram.
Okay.
IV.
Yeah.
Then there are antihistaminic steroids. Then there's ranitidine. Then
you talked about respiratory symptoms and signs.
Yes.
What
we can. There's bronchodilators we can use.
Okay.
Bronchodilator we can use.
Yeah.
And then
what will you do? You had a reaction in the OR. You managed it successfully.
Yes.
Then now the case is over. Then what next?
Then then we will explain the incident to the.
Would you like to?
First we will document it.
Yeah, that's true. That's true. Now the case is over. Case is over. Next, what? You will be. Suppose the patient is intubated. Now, would you like to extubate him?
No.
No, sir. Not at.
Yeah. What will you do?
No.
What can happen with the airway when there is anaphylaxis?
It can cause airway edema and
Correct.
there will be upper airway obstruction will be there.
Yeah.
So we need to wait till we are comfortable.
How will you know that? Suppose the patient is intubated.
Yes, sir.
And you want to extubate. So how will you know that it's safe to extubate in this situation?
If patient is conscious and on auscultation, there are no wheezing or no abnormal respiratory sounds, and lung compliance is okay, and there are airway pressures are normal, and patient is having this good.
Would you think about a cuff leak test? Yes.
Yes, sir. Yes.
Okay.
Yes, we will do the cuff leak test. Yes.
Yeah. Okay. Now, where would you like to keep this patient, in a regular ward or?
ICU.
I will shift to the ICU.
All right. Fine. So everything you have to, think about how you would actually do a case, and you just keep talking about it, isn't it?
Yes, sir.
Okay.
Yes, sir.
So all these things, any critical incident, you just tell the patient will be shifted to STU or intensive care unit. All right.
Yes, sir.
You have to mention all this, because then your management will be complete. Your management does not stop at managing the critical incident. You have to look at the whole thing as a spectrum.
Yes, sir.
All right. So in exam, without prompting, you have to talk about all this. Okay. It should come as a sequence. Okay. Don't miss that.
Okay. Yes, sir.
Yeah. Then what about? Would you like to do some tests?
Yes, sir.
Yes, please. Go ahead.
This is serum tryptase level.
Okay. How many samples will you be taking?
20 ml of the blood in glass tube is sent, and if within 1 hour we'll check the serum tryptase level. If it is raised, it's diagnostic of anaphylactic reaction. Okay.
So how many samples will you be taking? Only one?
I don't know, sir.
Okay. We'll be taking 3 samples actually. Okay.
Okay.
One is immediately after resuscitation, and one sample after 1 hour after the resuscitation, and then within the 24 hours. Okay. What is the half-life of tryptase?
No idea.
Yeah, it's about 3 hours. Okay.
Yes.
All right. And then any specific instruction at what temperature tryptase sample should be stored?
2 to 4 degrees Celsius. 2 to 4 degrees Celsius.
Around minus 20 degrees. That's what the book says. Okay.
Okay.
What are the normal values?
30 to 40.
Pardon me? Who's this, please?
Dr. Sumaira is.
Okay, Sumay Rajan. Okay. All right. That's not the normal value.
Oh.
Anybody?
Sorry, sir.
No problem. No problem. No problem at all. So normal is less than 11 nanograms per liter. Okay. So
Okay.
when do you consider it abnormal? You will consider it abnormal when it's more than 1.2 into baseline levels. Okay.
Okay.
So
Okay.
then it will be branded as anaphylaxis. So, okay,
Sir,
now we have done this.
Sir, please, once more, what is the normal value, sir?
Normal value is less than 11 nanograms per liter. Okay. More than 1.2 times of this, you can say it is anaphylaxis. Okay.
Thank you, sir.
All right. So you have done immediate management, you have done early management. Okay. Now next
Yes,
is
sir.
subsequent management. What is that you can do? Subsequent management?
Now, we will inform the patient and relatives
Yes. Yes.
about the incident. We'll
Yes.
fill the critical incident form, and
Yes.
we can refer the patient to immunologist for further workup.
Perfect.
And
Yes.
we can some card is issued to the patient.
Yes. Yes. What is that card? What color is it?
Yellow card, I think.
Correct. Yes. Yes. Okay. And any regulatory authority to be informed? Okay, it's called MHRA. This will just give you extra points if you answer. Even if you don't answer this, your points will not be affected. All right. It's called MHRA, Medical Health Care Produced Regulatory Authority. All right.
Okay, sir.
Okay. So we are done with anaphylaxis. Okay.
Yes, sir.
Yes. Next, Deepak, are you there? Dr. Deepak had volunteered. Hi, Deepak. How are you?
I'm good, sir.
Shall we start with LAST?
Sure, sir.
Yeah. Okay. So what are the types of local anesthetic that you know?
So there are two types of local anesthetics, esters and amides, basically.
Dr. Dayaram, you can switch off your video. Deepak, if you're okay, you can switch on the video. Otherwise, no problem.
Sure, sir.
Yeah. All right. Yeah. Yes. Yeah, Deepak, tell me.
So there are two types of local anesthetics, basically amides and the esters.
Okay. So what is the basic structure of a local anesthetic?
So the basic structure of local anesthetic is like two units combined with a connecting link.
What are the two units?
The two units are, one is the aromatic ring and the other the amine group.
It's an amine side chain.
Okay. Amine side chain. And
aromatic ring plus an aromatic side chain linked with the either a
ester
amide
or the amide group.
Perfect. Will you be able to draw the structure of a basic?
Sure, sir. Sure. Just give me a moment.
Yeah. Take your time.
Just a moment, sir, please.
Yeah. No problem. If you can draw, it will be great. Otherwise, no problem.
No, sir. I'll just draw.
Yeah.
I'm looking for the paper, actually.
Yeah. Sure. Take your time. No worry at all.
So it's aromatic with either ester or amide, then the amide side chain. So this is the basic structure. This is the aromatic ring connecting with ester or the amide link.
Okay.
With the amine side chain.
All right. Yeah. If they may ask you to sometimes draw the structure of lignocaine and bupivacaine. You can just these two structures you can prepare. All right.
Okay, sir.
Yeah, you can just practice lignocaine and bupivacaine.
Sure.
Okay, they can ask you sometimes. And this question is asked. Have you seen that EDAIC video of Viva in the ESAIC website? Sample video. They have put some videos. In one particular video, they have asked structure. Deepak, I think, yeah, your signal is a little bit weak, I think.
Maybe, sir, actually, today I'm not.
No problem. No problem. Okay. Sumaira has asked the ESAIC website, ESAIC, European Society of Anesthesia and Intensive Care website. They have, in the exam section, they have given some videos. All right. You can just see that. So, okay. Now, what are the common amides and esters that, can you name some of them?
So the common, we use mostly the amide groups like lignocaine, bupivacaine,
Yes.
ropivacaine, levobupivacaine.
Yes.
And some of the ester groups are cocaine, then
Okay, correct.
methocaine.
Yes. And
Cocaine.
EMLA, which one do you use? EMLA, which?
Prilocaine is also, sir, amide, I think.
Amide, yes, correct. And procaine. Procaine is an ester.
Procaine is ester. Procaine is ester, yes.
So you can remember CAPE, cocaine, amethocaine, and procaine.
Yes, sir.
All right. So how do the amides get metabolized?
Amides get metabolized, sir, through the liver. They usually metabolize through liver.
What, by which enzymes?
Amidases, liver amidases.
Very good. So what happens in liver disease or when there is hypertension and hepatic blood flow is low?
Yeah. Clinically, like their concentration increases in liver disease.
Correct.
But like, so we should avoid them basically.
No, you have to think about
lower doses.
the dose.
We should use in lower doses, basically.
Yes, perfect. And what about metabolism and binding? Binding of these things, these amide drugs?
Sir, like lignocaine is protein bound like around 70 to 80%, and
Yes.
the bupivacaine is like 25% protein bound.
Okay.
And bupivacaine, both are metabolized through the liver amidases. The metabolism.
Can you repeat what is the protein binding of bupivacaine and lignocaine?
Sir, bupivacaine is around 25%, and
are you sure? We are talking about not anionized fraction. We are talking about protein binding.
Sorry, sir. I think
it's 95%. 95.
Yes. Yeah. I think you're talking about the anionized fraction. Lignocaine is 25% and bupivacaine is 15%.
Yes, sir. Yeah, maybe. Yeah.
Okay.
Yes.
Yeah. Protein binding, bupivacaine is 95% and lignocaine is 65%.
Yes. Now I remember. Yes.
Yeah. All right. So if there is higher protein binding, then it will be longer acting or short acting?
So the protein binding basically decides the duration of action. The high protein bound drugs have got a longer duration of action than low protein bound drugs.
Correct. What are the chemical properties of esters? Can you pharmacodynamics and kinetics and metabolism?
Esters are basically metabolized through the esterases enzyme, non-specific esterases.
Correct.
They are possible allergens. They can cause allergy more than the amides.
Yeah, why is that so?
Because of the ester group.
Yeah, they break down to PABA and that can cause hypersensitivity. They can break down to para-aminobenzoic.
Yes, sir. Got it, sir.
Yeah. Okay. What are the mechanisms of action of local anesthetic?
The local anesthetics blocks the sodium channel from inside of the membrane in inactivated state.
Correct. Okay. Is that the only way? What are the two types of blockade? What you said is the open channel blockade. Is there any other mechanism?
Sorry, sir, I don't.
Other
Second is
mechanism?
closed channel blocker, closed sodium
Yes.
channel block. They dissolve in the lipid membrane and prevent the neural transmission.
Yeah, they cause membrane expansion by dissolving in the lipid membrane, and then they cause the channel blockade by physical blockade. All right.
Okay, sir.
Okay. So, what is the relationship of pKa and pH?
Because the local anesthetics are weak basic drugs. So for the weak basic drugs, the pKa is equals to pH plus log unionized part upon the ionized part.
All right. Now, how does what are the pKa of lignocaine and bupivacaine?
pKa of lignocaine is 7.9 and
Yes.
pKa of bupivacaine is 8.2.
8.4. Yeah. Okay. So, how much are the unionized fractions of
physiological pH of 7.4, more of the lignocaine is unionized rather than the bupivacaine. So more of it is available to diffuse readily, and so the lignocaine is fast acting, or has got shorter duration, shorter onset of action than the bupivacaine.
Yeah. Regarding this rate of absorption, okay, which are the blocks that have the faster rates of absorption? Do you know the order?
It depends basically on the blood supply in the vicinity. So the blocks where there's most absorption is the intercostal blocks, intercostal nerve blocks. Then the epidural blocks, epidurals.
Caudal, and then epidural. Yeah.
Caudal and epidural blocks. They are the most absorption, faster absorption.
Yeah. And then brachial plexus.
Then the peripheral blood blocks, like then the peripheral.
Yeah. And then subcutaneous. All right. So, what are the max doses of these drugs?
Lignocaine has without adrenaline it's 3 mg per kg, and with adrenaline it's 7 mg per kg. Bupivacaine is 2 mg per kg. Levobupivacaine also 2 mg per kg. Ropivacaine is 3 mg per kg.
Yes, very good. What about prilocaine?
Prilocaine is also, I think, 2 mg per kg, but I don't remember.
It's around 6 milligram per kg. Okay.
Yes, it's 6 mg per kg. Yeah.
They can ask you prilocaine because it is used in EMBLA, and sometimes EMBLA is used in pediatric cases. You know.
Yes.
So you may need to know about that. All right. Okay. What about ropivacaine? Did you mention about ropivacaine?
So ropivacaine is 3 milligrams per kg.
Yeah, it's 3.5 milligram per kg. Some books say it is 3 milligram per kg. It is safe to say 3 or 3.5. There is no problem. Okay. All right. What is CVS to CNS ratio? What does it implicate?
Pardon, sir?
Cardiovascular system to central nervous system ratio. What does it indicate?
So it's basically denotes the symptoms which will appear. Like the first symptoms to appear are the basically CNS symptoms. Then the cardiovascular system follows. So the dose which will the time or the dose which will take to follow the cardiovascular symptoms. So it is less bupivacaine rather than the lignocaine. So if the neurological symptoms have...
do you know the ratio of lignocaine and bupivacaine?
Sir, with the bupivacaine, I think it's somewhere 1 or 3. Then 7 with the lignocaine.
Correct. Bupivacaine is 1:3. What about lignocaine?
It's 1:7, I think, sir.
Perfect. Excellent. So can you tell me at what levels and what symptoms appear with lignocaine? Do you know the plasma levels?
Yes, so it depends basically on the plasma concentration. So at around 2 to 4 microgram per ml, there is headedness, patient may complain of dizziness, tinnitus.
Yes. Correct. Then
between 5 to 10 microgram per ml, patient may have visual disturbances. Then from around 15 microgram per ml, patient can have respiratory arrest, coma, tonic-clonic convulsions, and more than 25 microgram per ml, patient can have cardiovascular symptoms like arrhythmias and the cardiovascular arrest.
Yes, perfect. So how do you manage? You have a case of suspected local anesthetic toxicity. So how do you manage?
First of all, as the first symptoms appear, and as soon as we start suspecting, we'll declare it as an anesthetic emergency and we'll shout for the senior assistants, and then we will do some immediate management. So that will stop injecting the drug immediately. We'll ask the surgeon to stop the surgery. We'll the protocol of ABCDE. We'll start giving 100% oxygen to the patient. If the patient is not intubated, we'll try to manage the airway. If the patient is intubated, depending on the patient is intubated or not, then we'll check the circulation. We'll check if there is IV cannula patent or not. We need to take another IV cannula. Then, if the patient has got arrest, we'll go according to
Suppose the patient only has CNS symptoms.
Okay.
Yeah. First is CNS, right? So what will you do for CNS symptoms?
So after all these things, the patient has got CNS symptoms. Mostly they are present with the convulsions. So we'll give anticonvulsants, mainly the midazolam, benzodiazepines. So we can give midazolam or lorazepam, or we can give thiopental or propofol.
Yes.
Then if the CNS symptoms progresses to the cardiovascular symptoms, they can have cardiovascular arrest. If that is the scenario, we'll start the cardiopulmonary resuscitation according to the ALS protocol. In addition to that, we'll give the patient intralipid 20%. In the following doses. So doses are 1. We'll give the bolus initially of 1.5 ml per kg over 10 minutes.
Okay.
Then we'll start the infusion of 0.25 ml per kg per minute. If the symptoms are not controlled in
2.5 milligram per kg per minute, right?
Sir?
0.25 milligram per kg per minute, you mean to say?
Sir, in some books it mentioned ml per kg, in some books mentioned mg per kg, sir.
Yeah, you can safely say milligram per kg per minute, because this other one is the bolus dose you are mentioning in milligrams. So you can just mention the same here.
So bolus, the books which mention the bolus dose in ml, they also mention the infusion dose in ml. And the books which mention bolus dose in mg per kg, they also mention the infusion dose in mg per kg. But the dose is 2.5. So what's the correct, sir?
You just mention milligram per kg per minute. That would be the best.
Okay.
Yeah. Even bolus also 1.5 milligram per kg.
Okay, sir. So bolus is 1.5 milligrams per kg for 10 minutes, followed by the infusion of 0.25 milligrams per kg per minute. If the symptoms are not controlled in under 5 minutes, we can give repeated 2 bolus over in 5 minutes interval of same dosage. And after that, another 5 minutes, we'll start the infusion of. We'll increase the infusion to 0.5 mg per kg per minute.
Correct.
We have to continue the infusion as till the symptoms are controlled.
Yes. So somebody has mentioned in the chat as 15 ml per kg per hour. So when you convert this, it becomes in terms of ml, it will become 15 ml per kg per minute. But to avoid all confusion, better to stick to milligram per kg. Okay. Yeah. All right. And somebody has asked for the ratio. Lignocaine is 1:7 and bupivacaine is 1:3. Dr. Falguni?
Yes, sir.
Okay.
Yes, sir.
Yeah. All right. Okay.
Sir,
So,
lignocaine
1:7.
1:7.
Yeah. It simply means that you need 7 times more of lignocaine plasma levels to cause CVS effects compared to CNS effects. In bupivacaine, it takes lesser amount. So the margin of error with bupivacaine is far lower compared to lignocaine. Okay.
So if in the bupivacaine, if the CNS symptoms have appeared, so be prepared that the cardiovascular system is
very soon. Very soon. Yeah. That's all. Okay. So yeah. What is the subsequent management, Dr. Deepak?
Yeah. So the subsequent management after this, all this, we'll continue the infusion of the 20% intralipid, and then we'll chart the incident in the incident form. We'll inform the patient and the attendants, and yes,
correct.
This will be the
critical incident
form. Yes.
Yeah, critical incident form has to be filled. Yeah.
Yes. And we'll inform that patient and attendant.
Yeah, another thing that has to be remembered is that when you're doing CPR in these patients, it may take a longer time.
Yeah, okay? It may take more than 1 hour.
More than 1 hour, yeah. And if CPR is not successful, is there anything else that you can do?
If we have a facility of cardiopulmonary bypass.
Yes, yeah, please mention that. Okay, please mention that. Okay. Yes, yeah, someone is asking for the plasma levels and symptoms. Can you repeat that, Deepak?
Yeah, sir. So at the plasma level of 2 to 4 microgram per ml, the symptoms appear like lightheadedness, dizziness, and the tinnitus. Then the symptoms at the plasma level of 5 to 10 microgram per ml, patient may complain of visual disturbances. Then at the plasma concentration of more than 15 microgram per ml, patient can have tonic-clonic convulsions, respiratory arrest, and the coma. And the plasma concentration more than 25 microgram per ml, patient can have cardiovascular symptoms with malignant arrhythmias and the cardiovascular arrest.
Yes, perfect. Okay, now let's move on to intra-arterial injection. Okay. Deepak, have you prepared for this?
Yes, sir.
Yeah, okay, fine. So what are the risk factors for intra-arterial injection?
So the risk factors are maybe the patient factors and then the surgical factors. The patient factors include the site, where we are giving the injection, then the vicinity, and then
yeah, if the patient is anesthetized, he may not be able to complain of pain.
Yeah, if the patient is anesthetized, we will not
or
be
unconscious. Yeah.
Yes, sir.
Correct. Okay. Okay. Then what are the signs and symptoms?
So signs and symptoms: patient will complain of intense pain at the site of injection. Patient can have redness over that area. Then can have cyanosis of that part.
Yes. Yeah. Cyanosis and digital necrosis can occur if there is a severe reaction. Okay. So which are the drugs that are notorious to cause severe symptoms, and why so?
Most common drug in anesthetic practice is thiopentone, which is notorious to cause the intraarterial injection. And
okay, fine. What happens? It basically forms crystals.
It forms crystal, basically. Yes, inside it forms crystals.
Yes, it crystallizes and then causes this. Okay, so management.
So whenever patient starts complaining of pain, we'll just will not avoid that symptoms and will check the site. And if we are suspecting, like if it's on the basis of the anatomical site, we can suspect the patient can have an intraarterial injection. So we'll leave the cannula. First of all, we'll leave the cannula there, declare it as an anesthetic emergency, and call for the senior help. Then we'll leave the with this cannula. We have like 4 main targets. We have to dilute the drug. We have to dilute the system. Then we have to prevent the coagulation, and then
you talked about symptoms. So what is the more important symptom? First symptom?
Pain. Yes, we have to prevent.
So what will you give? Analgesia.
Analgesic. So for diluting, we'll flush we'll start the IV. That we'll start from the same cannula, IV fluid like NS, to dilute the drug. Then to dilate the system, we'll give piperine 40 to 80 milligrams, if available. Then for preventing the thrombus to form, we'll give heparin. Then for the analgesic, we'll use IV lignocaine.
So lignocaine, what all does it do?
Basically,
analgesia plus
analgesia, it provides analgesia, and in addition to analgesia,
causes vasodilation as
well. It causes vasodilation also,
yes. Okay. Yes. And this heparin, would you like to continue after the episode is over? And if so,
yes, sir, we'll continue the heparin.
For how many days?
For at least 2 to 3 days.
Around 1 to 2 weeks. That's what the book says. Okay. All right. So apart from this, is there anything else that you can do which can give you analgesia and vasodilation? Anything else?
Phentolamine.
Yeah, just we can give the sphenopalatine block.
Yes, correct. Excellent. Excellent.
We can
apart from
sorry, not sphenopalatine, stellate ganglion blocks.
Apart from stellate ganglion block, any other blocks?
We can give interscalene block.
Yeah. Suppose you don't have the expertise, you can give interscalene and or axillary. At least axillary.
Yes, sir.
All right. So again, the same things: documentation, critical incident report. Okay.
Yes.
Shift to ICU, and here you can also say I will refer the patient to vascular surgery. Okay.
Yes. Yes.
Yeah. So next question is and the last one is operating room power failure. I think Dr. Dayaram can take this. Dr. Deepak, is it okay?
Yes, sure, sir.
Yeah.
Yes, sir.
Thank you, Dr. Deepak.
Thank you, sir. Thank you.
Yeah. Yes, sir. Deepak, you can switch out the video. Yeah. Thanks. Yeah. Yes, sir.
Yes, sir. Yes.
So, sir, have you read about this?
Yes, sir. I've read.
Yeah. Sir,
I didn't get it from any book, but from the net.
No problem. Actually, I'll tell you, questions like this, they are bounces. Every paper will have one question like this. Every exam. Okay.
Yes.
So I in my exam, I had a question on team dynamics in the OR. Okay. So questions like this, you suddenly cannot, you cannot always prepare from the books that we have. What you can do is you can just use your common sense and you can explain. I just use some words like leadership and communication and all those things, and I somehow managed to score full marks in that question. Okay. In this also, you can just imagine if there is a power failure, what happens. Okay. And what are the things that we have to do. We just have to think about A, B, C, D, E here. Okay. And you have to continue to maintain that in whatever way possible. All right. Okay.
Yes.
So, so let's start with what could be the reasons where you can have a power failure in the OR.
So they can be. There are 3 types of supply in the hospital. One is mains power supply from the electric grid. So because of that failure, there will be power failure in the OR. Then there is a secondary supply, like diesel generators are available in case the main power fails. So if there is that can be defective, it can cause the power failure. Then third one is the uninterrupted power supply, UPS. That is for the equipment which are not battery power backup. So then yes.
So whenever there is a regional disaster like earthquake, or a tornado or a cyclone, or if there is a war situation, or there is an extreme weather situation, or if there is a local power grid disruption, okay, in the city, if there are power grids and if they are disrupted, and if there is some poor construction quality or very poor or shoddy electrical work, or there is a short circuit somewhere, all of this can cause OR power failure. Okay.
Power failure. Yes, sir.
What are the equipments you think in the OT that run on batteries, and there are some equipment which have no battery backup. Okay. So can you name some equipment which you think they have battery backup?
Our this monitoring equipment like multi-para monitors and infusion pumps, pulse oximeters, these are mostly battery backup these days. And even ventilator anesthesia workstation, in that ventilator is also this battery backup.
Yes. That's correct. So your vaporizer, does it need a battery?
Desfluran vaporizer,
yes.
And other vaporizer don't need, but desfluran vaporizer is electrically run, and
so it cannot work with
yes, sir, without power.
Because without power it cannot work. Perfect. So they actually did some study. This is just information. They actually did some study, and according to the manual presented with the anesthesia machine, it showed 90 minutes of battery backup. So they actually did some study, and they found out that the battery backup is actually for 3 hours, not just 90 minutes. And they found out that if they try not to use the ventilator, it is extended to about 4 hours. This is just general information.
Okay.
All right. So what are the things that do not have any battery backup?
This electrosurgical units.
Correct.
Then video displays.
Most importantly, the surgeons are operating under light. So the light will go. It doesn't have any battery.
OT light. Then suction machines.
Yes. Correct.
Then our this AGM.
Correct. Perfect. Yes. Okay. So now we know which equipment have battery backup and which don't. Correct. So to substitute this things that don't have battery backup, so what all can you use?
For the light, we can have in the OT alternate this battery powered light source.
Yes.
Or we can use the flashlights of our cell phones or laryngoscope blades.
Yes. LED lamps, headlamps.
Yes, sir.
So there is suggestion that there can be an emergency monitoring kit. So what all should that include?
This emergency battery powered light source, then the pulse oximeter, and this manual sphygmomanometer.
Correct.
Then this this self-inflating bag to ventilate the patient. Then oxygen cylinder.
Yes.
Then yes.
Correct. So with regards to CO2, you can have a colorimetric CO2 monitor, which changes color when So suppose you intubate and you need to make sure that it's there. So you can use a colorimetric CO2 monitor. Okay.
Yes, sir. Yes.
So next, how do you manage an actual situation?
So whenever there is a power failure,
suppose there is a surgery going on, and now there is a full complete power outage. Then just take us through how you manage.
There are two issues. One is regarding the patient, and other is regarding the power source. So the one who is taking care of the patient will immediately ask for help and allocate the different persons for different roles. One will arrange the alternate light source, so that and then we'll see immediately whether patient is being ventilated or not.
Yes.
If ventilator is working, then we are free to do other work. Otherwise, first priority will be to ventilate the patient. We'll need to have the manual ventilation, and then we'll check the other monitoring equipment whether they are working or not, like pulse oximetry.
Would you like to have a certain amount of FiO2 here?
Yes, sir. We'll at least if there is we feel that oxygen may fail, then we will use lowest possible FiO2 and lowest low flow ventilation. We can use.
Just switch over to 100% FiO2.
Yes,
you cannot
yes,
take any chance. Okay.
Yes,
in the
immediate
you can use lower flows You can reduce the 2 liters per minute, but FiO2 has to be 100%. You cannot take a chance.
Yes, sir. Yes,
okay?
Yes, sir.
Yeah.
Yes.
All right. So if the ventilator is not working, you will go on to manual, correct?
Yes, sir. Yes.
All right. And then you will arrange for a light source with these headlamps.
Yes. Then we'll coordinate with the local authorities to have the information about the extent of the power failure, duration of the power failure, whether there are any chances of failure of any oxygen or something.
Okay. All right. And then anything else you would like to have by your side? You can have an ambu bag, okay?
Yes.
Just in case the anesthesia machine fails, and then you will have the oxygen cylinder, okay?
Yes.
Full oxygen cylinder. Suppose you have to maintain this.
Yes, sir. We need to see the content of the oxygen cylinder also, and if possible, one more cylinder we need to arrange.
Correct.
If we feel that this power failure will take long time.
Yes. Okay. And then you can also there's a triage which you can do. I found this triage on the internet. I'll share it in the group later. So there is color codes for red, yellow, green, blue, and black. Are you aware of this?
Yes, sir. I read this, but I don't remember exactly.
Red means patient requires immediate evacuation within 30 minutes. Okay. Out of the OD. And yellow means patient can wait 30 minutes to 2 hours. Green means procedure can be aborted immediately. Blue means patient can be discharged home straight away, and black means deceased. I'll just share it on the group later. All right. So now there is a question of monitoring. So what will you do with your monitoring kit? Just like the machine used to take every 5 minutes, you have to monitor
every parameter.
Every parameter. Heart rate. Yes, we can have a hand on the pulse.
Yes.
And then the pulse oximeter is there. That will also show you the heart rate. Correct. And then every 5 minutes you can read the BP, blood pressure.
Yes, sir.
And hand on the pulse will also tell you the pulse volume, and you can keep auscultating in between. Correct.
Yes,
to see if the ventilation is going all right. Okay. So then how do you maintain anesthesia and analgesia here? What would be your strategies here?
Sir, if there is this we are using inhalational other than desflurane, we can continue that vaporizer.
Correct.
Or otherwise we can use this intermittent bolus propofol, or we can use this propofol in the this IV drip.
IV drip. Also. Correct. Any drug which is both analgesic and also it's an induction agent. Anything?
Ketamine, sir.
Perfect.
Yes.
So you can use ketamine. You can use some midazolam to prevent awareness. Okay. And you can use opioids to maintain analgesia. Okay. To somehow tide over this situation. Okay. And then as far as possible, if ask the surgeon to finish the surgery as soon as possible, so that you can,
yes, sir.
The patient is out of.
We'll need to discuss with the surgical team about the
feasibility of
feasibility. If it takes long, we need to, and patient is stable, we can ask the surgeon to wait and pack the wound and leave it open for the when the power resumes.
Yeah. So a question like this you can answer with little understanding of what you would be practically doing in these situations, and you can somehow get through these questions. Okay. There is nothing to worry about. All right. So we finished the session, today's session. And
one question, sir.
Please.
Sir, you mentioned that in case of this power failure, we need to be on the lowest, like 100% oxygen with the minimum flows which we can use. But the photograph.
If your anesthesia machine is working, and if there is any anticipation that the main oxygen supply may fail, so until then you use low flows. Okay.
But to extend the oxygen supply, the oxygen source, they have mentioned that we have to use the minimum possible FiO2.
You use the minimum flows on the flow meter, and to prevent any desaturation, which may not be caught on the monitor. Sometimes if monitoring fails, so you can't take a chance, right? So where is the source that you...
That photograph which you shared, they have mentioned that the minimum possible FiO2 we have to use.
Deepak is talking about this oxygen failure alarm. If there is oxygen failure, total oxygen failure, then we need to have the lowest flow possible and lowest FiO2 possible.
Okay.
If there is power failure, practically we always, in any situation, we always give 100% oxygen as immediate.
Yeah, just switch to 100% oxygen to be on the safer side. All right.
Okay, sir. Okay. Thank you.
Okay. Thank you very much, everyone.
Thank you.
We'll meet soon again. All right. Good luck. Who's taking exam this month? Anyone? Okay.
No.
None of you? All right. No problem. Yes, doctor? Somebody had a question? Yeah, one topic is left, but that one we had already covered in hypoxia. So I thought I'll omit it this time. It's the same. It's almost the same.
Okay, sir.
All right.
Okay.
Thank you. Thank you very much.
Sir. Thank you.
Yeah.
Thank
Bye.
you, sir.
Bye. Good night.
Good night.
All the best. Bye.